you please type them into the chat. We will have time at the end for questions and answers. I'm very excited to have Dr. Lewis here. He is a orthopedic surgeon. He has a extensive history, and I'm going to let him kind of explain more what he's done. And he's kind of a newbie to Florida here, so we'll let him kind of share a little bit of his background as he's coming into this. But our elbows and wrists are so important, and they're what kind of we reach out to the world with. So we want to make sure we're taking care of them. And if we do have an issue, we know where to go. So Dr. Lewis, I'm going to turn it over to you.
Great. Thanks so much, Jean Marie. Just a little quick background here. Years ago, I got a business degree from the University of Georgia, and I wanted to move down to the Tampa Bay area, so I did. But I found that I was still attracted to the science, and having a father as a carpenter and a mom as a nurse, I thought orthopedics would do well. So I went to medical school at USF over in Tampa and did some residency in Georgia and fellowship up there. Worked up there at a hospital to develop a sports medicine program for about 7 years, and then went into solo practice for another 7 or 8 years. And I decided, well, I kept finding myself coming to Florida, enjoying Florida. So I decided to move the practice down, and I've recently done that this year. And we're over here in Largo, Florida now. So yep, got a doctor with a business degree. And I'll tell you, it's real interesting. Having a business degree taught me a lot about how to be a doctor, and being a doctor taught me a lot about how to be a good business person. So it's interesting how there are a lot of parallels, but that's a talk for another day. So today we're going to talk a little bit about some common hand and wrist ailments and injuries. So objectives for the talk today, we want to make sure that we can discuss some of these things. We kind of recognize them. We want to gain some clues and to help maybe diagnose it. Not that we're going to try to teach you how to become a clinician, but, kind of, hey, what's going on with Aunt Janet's hand over there? What's that bump on my daughter's wrist? Things like that, and just simple things. And then understand some basic treatment so you can kind of know whether or not you might have to seek care at an urgent care center, or go see a hand surgeon or an orthopedist to kind of, or your primary doctor, to see if that's something you need to take care of. So we'll start off. Let's see that dented fingers. We're going to start off with fingertip injuries. We'll talk a little bit about partial amputations and nail bed injuries. Finger infections are also included in some of the things we'll talk about today, or paronychias or felons. We'll describe those. Mallet fingers, also known as kind of a jam finger. Gamekeeper's thumb, we'll talk about that. It's also been rebranded as skier's thumb recently. We'll also move on to talk a little bit more about finger dislocations, yet another jam finger mechanism of injury. Maybe some bumps on the fingers, which we know as mucus cysts, and we'll get into that. Trigger fingers, a little bit about arthritis, and fractures is kind of sprinkled a little bit here and there in the talk. They're pretty obvious once you have a fracture and you have a deformity. So those are kind of in the talk, but not as much as some of the other common things that we'll see. Moving to the wrist, we'll talk a little bit about carpal tunnel syndrome, and that is a nerve issue that we're going to see in the wrist and the hand. We're going to also talk about de Quervain's tenosynovitis or tendonitis of the wrist, and also rounding up the talk, we'll talk again a little bit about ganglion cyst, Bible cyst, and things like that. So starting out, fingertip injuries, we'll start with some partial amputations. Partial amputations can occur by just about anything. It can be a knife, it could be a saw. Maybe we've got a lot of do-it-yourselfers in the audience. You can have a table saw at the house. You may like to work with a circular saw at work, or maybe you don't like to, but you have to. You can get a kickback from that circular saw, or reciprocating saw, or some people call it the sawzall. If it's not held correctly, and that long blade can catch on the wood and kick back, it could catch your other hand. Doors, whether they be car doors, home doors, sprockets, maybe you're changing the change on your chain on a motorcycle or your kid's bike. If you get that finger in there just right, you could experience a fingertip injury. Going through some of the anatomy just to kind of help us understand things. Our fingertip, we always call this the fingernail, but we call it the nail plate. That's the hard part. Underneath that is the pink part, and that's called our sterile matrix. Okay, but the little white part here, called the lunula, actually gives birth. It's called the germinal matrix, and it creates the nail plate, which then delivers in this direction like a conveyor belt, and that's why our fingernail gets longer, and we have to trim it every now and then. Now that's important because right underneath this sterile matrix is the bone. So right between the bone and our fingernail is that pink stuff, and that's it, nothing else. So if we ever get a fracture of this particular bone, it's very close to the sterile matrix, and if that fingernail comes off, we're typically dealing with an open fracture. And we'll kind of get into that here in just a little bit. So fingertip injuries, we talk about partial amputations. They can be dorsal oblique, transverse, or volar. And we describe that in the orientation of this amputation. For example, if you amputate in this direction and the face of the bed faces the ceiling, we call it a dorsal oblique. If it's facing straight out, we call it a transverse. But if the face of the amputation is facing down, we call it a volar. Now that's important because in this particular amputation, we have a lot of skin underneath here that we could use to advance to cover the exposed bone and so forth. We have a little less so in this and hardly any with this type of partial amputation. When we're describing this, we talk about the treatment for it. The dorsal oblique, we have what's called a VY flap. So we can actually cut the skin that's remaining in the shape of a V. We can advance that, taking the fat tissue with it to recreate the pulp that we saw in that anatomy picture. And when we close it up, it looks like the letter Y. So that's why we call it a VY flap. Transverse obliques, we typically can just close those. And if it's a volar oblique, we may have to shorten that bone. We don't have much skin for that VY advancement, so we may just have to shorten the bone and then close it primarily. Fingertip injuries can also involve an open fracture. So if we have an open fracture, or if we lost the fingernail and the fingernail is gone, and we look down and that sterile matrix or that pink part is real beefy looking and beat up, that's likely an open fracture, because recall again that that sterile matrix is the only tissue between the bone and the nail plate. And if the nail plate is gone and this bone is sticking up, that's definitely an open fracture. That requires urgent attention at an emergency department. Typically, we're going to go ahead and wash that out. We're going to straighten that bone. We're going to repair the nail bed so that that pink sterile matrix is now repaired, so that when the fingernail grows back, it has a nice smooth surface on which that conveyor belt, and we're recreating the conveyor belt so the product on top can come out and have a nice outcome. Fingertip infections can involve things called a paronychia or a felon. Paronychia is typically an infection, as you see here, bright red, angry, hurts, very tense, and it occurs right beneath the nail, right above the nail plate or the fingernail, but underneath this skin or the nail fold. So it can accumulate right in this area. And if that happens, then it can't come out because that skin or the cuticle kind of area is attached. And that's how we treat it. We can elevate this right here, maybe let some of that pus out, but we want to make sure we get folks on a good antibiotic to treat the infection. A felon is typically talking about the digital pulp, and it can be an infection that occurs up in here. And so your fingernail or fingerprint rather would be very angry and swollen. And the treatment for that is typically through an incision. You can see here in this particular diagram where we may make the incision right on the fingerprint. I don't like to do that because that's sore afterwards when it scars in. I like to prefer this. Or I prefer this method where we make the incision on the side. You can go underneath, allow that pus to come out, and obviously we're going to treat them with antibiotics. And depending on how you got this infection, maybe you're walking your dog and you corrected your dog and they bit you back. We're going to treat you with augmentin if you have a felon there. Or, I have here listed as a human bite. Not that a lot of us are out there biting each other, but if it happens, we need to know about it. We treat you with a different antibiotic. IV drugs are sometimes necessary, IV antibiotics for people who may have like diabetes or IV drug abuse, for example. Mallet finger is another issue we can see, or another ailment we see in the hand, and that's where you jam your finger. And what happens is, maybe this happens when you're catching a football, maybe you're at a tailgate, or maybe you're out in the backyard with your kid, or who knows, maybe you catch a baseball thinking you can do it without the glove and it hits your finger, and it forces the finger down from a straight position down. And what happens is then you will rupture the tendon, or you can rupture the tendon, and then or it could take a piece of the bone with it. Now it's important to be evaluated for this, because if we do take a piece of the bone, we treat that sometimes differently depending on the size of the bone than if it was just a tendon rupture. We classify these as either acute, meaning they're less than 4 weeks old, they're chronic, greater than that 4 weeks period. We classify them as closed injuries or open. Maybe it's a laceration. Maybe it's going to be an abrasion, like if you were in a motorcycle accident or something, or it could be a fracture, as we see here. Swan deformity can be a consequence of a chronic mallet finger that's not treated. You can see here, this finger is not able to go up. You lose that extension because that tendon is ruptured. And then you try so hard that you hyperextend this joint. So you have hyperextension of this joint and then flexion of this joint, which creates the quote unquote swan deformity. We evaluate these, of course, with x-rays to see if that bony fragment is large enough. And if we can treat this with a closed injury and there's no big bony fragment, we can usually put folks into what's called a stack splint. And that's what this plastic splint is. We tape it to the finger and it holds the finger up so that it will stay extended. And basically what we're doing is trying to reapproximate the tendon edges that are ruptured so they can heal. If the finger is bent, the tendon edges are separated, and it's kind of like healing cells. Sometimes when you have a gap of 1/4 of an inch, it's like the Grand Canyon for healing cells. They like to be a lot closer, so we want to splint it, get it lined up so that it'll work out and heal. Now, if you cut yourself with a knife, perhaps at the kitchen sink when you're washing dishes, you could develop a mallet finger from that because you cut the tendon. We're going to repair that. And if there's a large mallet fracture or bony piece, we're going to go ahead and repair that as well. Gamekeeper's thumb is another injury. This is where your thumb is hyper abducted or moved away from the hand. So the thumb is actually forced that direction very, very abruptly, and you can tear a ligament that lives right here on that thumb joint itself. Now, just like in the mallet finger, it can be a rupture of the ligament. Mallet finger is a tendon, but this is a ligament, and it can take a little piece of bone. Okay, so that's why we gotta sometimes x-ray these, because they can be different treatments based on the x-ray findings. We're going to examine the patient carefully. We're going to go ahead and try to examine them with the thumb at 0 degrees, with this thumb at 30 degrees, and we pull out. Now, if there's not much of a pull, that means it's probably a sprain. We don't have to operate. But if they have a really large deviation from normal, greater than 30 degrees, we sometimes think that they've ruptured a lot of the ligaments and they need operative fixation. And what happens in that case is we have this aponeurosis here from a small muscle called the adductor pollicis. And when that thumb starts to get bent out, this aponeurosis can actually get stuck between the torn ligament edges. And if it's stuck between the edges, it will never heal. So if we ever examine you and it's really an impressive examination, the answer is surgery right away. So that's why sometimes these things need to be evaluated pretty quickly. If you have a stable exam, we can put you in a splint, do it for about 4 weeks. It heals up. Just like if you sprained your ankle, it's going to be a several week kind of bracing type issue. If it's an unstable exam, like I just mentioned, it requires operative intervention, because about 8 times out of 10, you're going to have this lesion. And I failed to mention that on the previous slide. It's called a Stenner lesion. And we want to make sure you don't have a Stenner lesion, because if you do, you'll never heal that thumb and it'll always be super loose. Finger dislocations can occur from another, like a jam finger. You can get the mallet finger from a jam finger, or you can actually dislocate your finger. You could fall down awkwardly, maybe, chasing your dog or playing football or soccer or whatever you like to play, and you can dislocate your finger. And just like in the gamekeeper and the mallet finger, something ruptures. So the volar plate in a dislocation, the structure down here, ruptures. Okay. Sometimes it can just tear. Sometimes it can take a little piece of bone, just like in the other injuries we were talking about. If this little piece of bone is small enough, we just kind of leave it alone. If it's a big piece, more than 50%, we call it unstable, and we have to fix it. So that's why it's important for this to be evaluated if you dislocate. It could be something that you reduce or you pop back in on the field, and we do that commonly, but you should have an X-ray follow-up at some point. Here is an x-ray. We're going to x-ray these people. This is an obvious dislocation of the knocking knuckle. Doesn't look so bad right here. It's a subtle finding, but there's the dislocation. We're going to pop that back into joint. We're going to go ahead and get an x-ray to make sure that it's not an operative problem. And if it's not an operative problem, we can usually treat people in what's called a 30-degree extension block splint. So here we just bend a piece of aluminum. It just comes out of one of those blue finger splints you might buy at CVS. We wrap it with some Coban, and then we create about a 30-degree bend in it. They can bend the finger, but they can't straighten it past 30 degrees. And once again, we want to make sure that that volar plate, those edges down here, are reapproximated so they can heal. And we'll place patient in this for typically 3 to 4 weeks. After that, they can start to resume activities as tolerated and move on. But long-term splinting in this without any flexion is a bad idea because it'll promote a stiff finger. Next is trigger fingers. Maybe some people out there have something like this. Trigger fingers are typically when the finger will lock up in the palm and it'll get stuck there. You may wake up in the morning and your finger is bent into your palm and you can't pull it out. And then when you do, it hurts. In the palm, there's this nodular, diffuse type of swelling, perhaps in the tendon, and it can cause the tendons to snap and pop. Now, here's we have the anatomy of the finger. And in the finger, we have these tendons that come out and they will make the bones move, right? Well, they had to be held close to the bones. So we have these pulleys. There's a pulley here, pulley here. We call these annular pulleys. Here's some that look like X's or cruciate. We call those cruciate pulleys. And that the A1 pulley right here, that's the most common site for a trigger finger. If the tendon right here gets a little bump and then it goes underneath, it can't come back. And that causes a trigger finger. It's more common in females and males, worse in the morning, and the ring finger seems to be the predominant finger, but it can occur in all fingers, and we've seen it in all fingers. So usually the finger would look like this, and then we did have a video. It's okay that it doesn't work, but then this gentleman pulls it down on the finger, and then he tries really, really hard to straighten it, and eventually that finger just literally snaps right out of the palm. So typically patients will say, wow, I can't fully flex my finger. It really, really hurts. It gets locked up. It clicks, it pops, it gets stuck at night. They may have a nodularity in the palm area where they say this really, really hurts. And so that's how they'll present to the clinic oftentimes. The treatment is typically based on how bad it is. In this picture, you can almost see the nodule that now got stuck on this side of the pulley. And if we release that pulley, if we just cut right through it, you can see how that nodule could slide back and forth. And actually, that's the treatment if we conservatively fail to treat these. So if there's just a little crunching, 0, maybe an uneven motion, maybe it clicks, maybe it does lock, but you can pull it out. But if it's locked, we need to get in there and fix it right away. We can inject these. We can offer physical therapy. Some work. Sometimes the injections work. Sometimes they don't. If a failure of grades 1 through 3 is what we see, we release the A1 pulley. It's an instant cure. It takes 5 minutes to do. High satisfaction rate. Patient loves it. You don't have to go to sleep from the procedure. It's just local anesthetic at the surgery center. You don't even get off your stretcher. We could almost do it at the drive-through if they would get a drive-through over there, but we'll see one day. Basilar arthritis is another discussion. Arthritis in the hand, there's a lot of it, but this is kind of one of the more common things I'll see. Basilar arthritis is arthritis at the base of the thumb, and it occurs right here. And what happens is, if you notice, this is a saddle joint, okay? Looks like a horse saddle right here, and there's another saddle up there. When that ligament right here, called the beak ligament, starts to attenuate or gets loose, the joint starts to partially dislocate, and that creates loading of the joint, rapid arthritis, and it hurts. Okay, and this is typically something we'll see. And yes, females, you win again. It's more common in females than males. But the good news is this is a highly successful treatable condition with conservative measures. On examination, we're going to x-ray the patient. We're going to see if they've got advanced arthritis, and they're going to be tender right here. It's going to be at the base of the thumb, right there, every single time. It's like the home run examination for CMC or basilar arthritis. We can also do a grind test where we just take the thumb like a joystick and grind it into this area, and that hurts. And that also is a very good exam technique. The treatment is going to be based Typically, well, we treat them all the same initially, whether they're grade stage 1 or stage 4, but this is just kind of a classification scheme we see. And this is an example of really, really advanced thumb arthritis. This part of the thumb right here, this bone, used to live up there, but it has partially dislocated nearly half an inch over the years. And this nice lady developed this huge bone spur. You can see her, it looks like a big piece of cauliflower. Okay. But she wasn't even here for that. She was here for a wrist fracture, which you see right here. I treated her for a wrist fracture. That's what she came to the clinic. But I like to use her X-ray because she didn't even hurt. She said, "Yeah, I got a funny looking thumb, but it doesn't hurt." She was kind of in her late 70s, early 80s, but she was there for her wrist fracture. So a lot of times you can have this advanced arthritis, but it may not even be symptomatic. So initially, we're going to treat them with non-steroidal anti-inflammatories, occupational therapy, maybe a brace. We can do injections. I've even done PRP injections in this particular joint with very good success rates. But if we ultimately have to come to it and the arthritis is there, if you have knee arthritis, you get a knee replacement. Hip arthritis, hip replacement. We don't have that necessarily for this joint or one that's really effective. So what we do is we go in here and we'll excise that bone that's arthritic. We cut it out. There it is. It's gone. We're going to recreate the ligament up here, take half of the tendon, run it through a tunnel, and then we're going to roll it up like a big wad of gum and stick it in there as an inner position. And then that's going to recreate that anatomy that you once had. And this is just a picture of one of my cases where I actually took the bone out. I took out part of the other bone because she had arthritis along this whole ridge here. And we just reconstructed it, and that's what it looks like from an X-ray standpoint. Carpal tunnel syndrome is next on the list. This is kind of in the wrist. What we see here is a nerve issue. This is the most common compressive neuropathy of the upper extremity. And this is a pressure phenomenon. There is a carpal tunnel in our wrist, and the nerve that lives in that carpal tunnel is under pressure. So if we look here, the carpal tunnel is made of carpal bones, which is Latin for wrist, and we have HAM-A, we have the capitate, trapezoid, and trapezium. So we have 4 bones, but then on the top we have a ligament. On the next slide, it looks a little bit better. So here is our bony tunnel, and there's the roof. There's our carpal tunnel. It's a tunnel. Now, I have had people call it a copper tone tunnel, but it's not that. It's a carpal tunnel. And it's kind of funny what a lot of people call this. But, and I'm sure a lot of you are kind of snickering right now, but what we see is inside this tunnel, we have 9 tendons and a nerve. Now, the tendons, if they get pressurized, they don't really feel it, but the nerve does. So this is a pressure thing. The normal pressure in the carpal tunnel is about 2.5 millimeters of mercury. If edema or swelling occurs around each of those 9 tendons that I mentioned, the pressure can go up. There could be a tumor in the tunnel. There could be an infection. That's unusual. Maybe you broke your wrist in a car accident, and then that fracture is displaced, and then all of a sudden that pressure goes up. It could be caused or seen in people who are alcoholics, diabetes, hypothyroidism, things like that. But those are some predispositions, but ultimately it's a pressure phenomenon. People are going to complain typically of not a pain at night. Numbness or tingling in the thumb, index, middle fingers typically is what I see. They shake their hands, it feels better. They'll hold their hand up on their head like this. That feels a whole lot better. It takes it away. It gets worse with driving, maybe using a mouse at work. And sometimes they'll complain of being clumsy or weak. I just dropped something. I dropped my cup of coffee, or I let it slip in my hand, spilled it all over my shoe at work the other day. So that can actually be a presentation of patients. Clinically, we're going to do a good neck exam. Could have a pinched nerve in their neck, right? Maybe they have a herniated disc. So we want to do a good neuro exam, make sure that that's not what it is. Check their sensation, a light touch. 2-point discrimination. Can they discriminate 2 points on their fingers? If you can do this to within 6 millimeters, that's typically normal. If it's greater than that, that's abnormal. We're going to look at the thumb. We're going to see if it's atrophy. Did the muscles shrink away? Can they move the thumb? Can they oppose the thumb across to the small finger like that with some reasonable strength? And those are other things we're going to look for. We're going to also test them with what's called a Tinel sign. We can tap on the nerve on the wrist right here, and if that sends electricity kind of finger sensations down the fingers, then that's called a Tinel sign. We can flex the wrist like you see in the picture. That's called a Phalen's test, usually for about 60 seconds. If they're positive in 15 seconds and they say, yep, there it goes, there's that tingling and numbness I have at night, that's considered a positive test. You can move on. We also do what's called a Dickens median nerve compression test, or repression right on pressing right on the roof of that carpal tunnel, and we're intentionally trying to increase the pressure in the carpal tunnel. In orthopedics, we're always trained, provoke the pathology. If we can provoke it in a test, we can probably diagnose it accurately. And again, you don't have to hold it for 30 seconds. If they're positive in a few, you can move on. Typically, we get an x-ray, but it doesn't always give us that slam dunk answer that this is carpal tunnel. It's more of a clinical diagnosis, but we can get what's called electromyography studies or nerve conduction studies, where they'll stick little needles in the muscles that surround the wrist, elbow, and even up to the neck area. And that can tell us if there's compression across the carpal tunnel, or if there is a herniated disc causing what's called a pinched nerve or cervical radiculopathy. And that we want to know, because if I do a carpal tunnel release on a patient who has a cervical radiculopathy, they're not going to get any better. It'll be kind of fun for me because I love to operate, but they would not get any better, and that would not be doing them any kind of good service. So we try to make sure we get it right before we operate. Carpal tunnel syndrome can exist even if the nerve study is normal. It may not even be present at the positive EMG. So you have to kind of talk to the patients clinically about these things and what to do next. Treatment is going to be, of course, operative release in acute cases, and we're going to recommend night splints for those to decrease we're going to recommend splinting. So when your wrist is bent like this, the pressure in the carpal tunnel goes up. When the wrist is bent like this, it's going to go up. Guess what? We all sleep like this. We have those wrists, we're just kind of like this, and the arms are kind of bent. But if you wear a splint at night, keeping your wrist straight, your chances to decrease your pressure is going to be best at about 2 degrees. And that's why we recommend splints. Put it on your nightstand, put it on at night, or leave it on your nightstand, put it on at night, take it off in the morning, go to work. And you can wear it at work too. But typically that's the treatment. Non-steroidal anti-inflammatories, physical therapy, injections. Vitamin B6 hasn't really been clinically shown to be a great treatment for carpal tunnel, but it's a cofactor in protein synthesis for nerves, so it's not going to hurt you, but it's not going to be that silver bullet to get rid of your carpal tunnel syndrome. Ultimately, if that fails, we're going to release that ligament right there. And once we release it, all the pressure is out. It's kind of like taking a notch out of your belt after Thanksgiving dinner. All that pressure is released, and the carpal tunnel can breathe again with very, very high satisfaction rates, very, very good outcomes, very quick procedures, well, like a trigger finger. Quervain's tendonitis, that's another one in the wrist. We have these compartments. If you look at the back of your hand, so the back of your hand, and you wiggle your fingers, you can see all these tendons moving here. Well, they move in the hand, but at the wrist level, we have these compartments, kind of like the trigger finger has compartments, and all these tendons are held still in compartments. Sometimes this compartment number one can get angry and it gets inflamed, and you get what's called de Quervain's tendonitis. And what happens is these two tendons right here, which are held by a strap, they get really, really tight. And what we found is that this is actually a degenerative process. And here we go again, women. Sorry to pick on you, but you're going to get this a little more often than men. And so I think you guys are winning all the races today. We do know that the tendons are thickening. The retinaculum that surrounds it, or the pulley that surrounds it, is thickening. And we do have some risk factors, things like that, like repetitive motions and things like that. But we'll go ahead and bring people in the clinic. They're going to have pain here at the radial styloid. They're not going to have pain here like basilar arthritis, but we have to rule that out. They're going to have pain here. And we do this test. We put the thumb in the fist, and we do deviation to the small finger, kind of like a karate chop, or for all those FSU fans out there. So that is going to provoke the tendons, once again, provoke the pathology, and it feels like it's burning or ripping, and that's called a Finkelstein's test. Okay? Usually x-rays aren't necessary, but we typically get them. Treatment is going to be rest, ice, therapy, maybe a thumb spike, a splint, and even an injection. And if ultimately that fails, we can release that compartment, just like we release a carpal tunnel. Those tendons can breathe again, and folks feel a whole lot better. Rounding out the talk here, we have benign bumps on the hand, ganglion cysts. They're typically close to joints. We can have some on the back of the wrist. Some you might even have here at the tip of the finger. We call those mucus cysts. They're also ganglion cysts, but we just call them mucus cysts. But you can have a cyst on the back here of the hand called a ganglion. Maybe your daughter has this, common in teenage girls and so forth. But what's the theory? Why does this happen? Well, one theory is that the fluid herniates out of the joint. But I think the more common accepted theory is we have a hole in the joint, it leaks, Then we create this pseudo capsule around the fluid, and that creates the subsequent ganglia. They can fluctuate with size because they are connected to the joint. Here is a volar radial ganglion that's near the radial artery. We have to be careful about that. If they get really tight or tense, then they can hurt. Here's one here. They used to be called Bible cysts because that was a form of treatment. You can hold your hand like this and have your friend whack it with a big hard Bible, and it can rupture this cyst. And they actually did that. Funny story, when I was a resident at the VA, the guys drove down to Augusta, Georgia from Atlanta, and he said, that didn't work. And I said, what'd you hit it with? And he said, well, I hit it with the yellow pages from Atlanta. And at that time, those yellow pages were probably this thick. So, but it was softback. I told him, try it with a hardback book next time. So I don't know if he did it, but that probably was a great recommendation. But nowadays, we don't hit things with Bibles. We puncture them, or we stick a needle in there. We can aspirate it. We can surgically excise it as well. But these are benign entities. They do not have to be removed. If your boyfriend's not digging it, or your girlfriend's not, or your husband or your wife say, I can't stand the bump anymore, then you get it removed. But if you want to just observe it, you can, as long as you'd like. So in conclusion, we talked a lot today. We talked about some fingertip injuries, which include amputations. There's finger infections. Make sure you get those checked out. You might need to be on antibiotics. Mallet fingers, again, ruptured the tendon or bone, needs an x-ray to be treated effectively. Gamekeeper's thumb. Also, the reason they used to call it gamekeepers, I think I missed this part, is the Scottish gamekeepers back in the day would break the neck of their rabbits, and that would sprain their thumb. But now they call it skier's thumb because it's more seen, I guess, in skiers and like who go down the hills with the skier poles, and that can hurt the thumb. We talked about finger dislocations. Again, they could be bony, so get an x-ray. Trigger fingers can be annoying, and if they are locked, we have to release them. If the conservative treatment fails, we can release them. Basilar arthritis of the thumb, highly successful with conservative treatment. Carpal tunnel syndrome, again, the number one nerve, compressive neuropathy in the upper extremity, can be treated with injections, but ultimately may need to have a release. I know there seems to be a lot of folks out there that think that carpal tunnel releases can be dangerous, but I've got great results, and I think it's a very straightforward procedure if done correctly, with very, very high satisfaction rates. So if you're scared of it, we can always have a conversation. Tendonitis, again, that can be released or can be injected. Ganglion cysts, don't be scared of them. They're benign. But, if you want them out because you're not really digging the cosmesis, that can also be arranged as well. Thank you.
Thank you so much. That was awesome. A lot of information. I think we take for granted that our hands are so involved with so many things until something happens to them and we need to figure out what's going on. We do have a number of questions. So I'm going to kind of group some of them together. But one was someone has trigger finger and they had 3 injections. What's the next step if the injections really aren't working for them and they're having that trigger finger? Is that where they would go for a surgical procedure then, or is there other paths?
I think that is definitely the next path. There's been some literature that would suggest that if you have an injection and then 4 weeks later you had a repeat injection and it didn't work, the chances of that conservative pathway of succeeding is very, very low. The release is a very quick release with great results, high satisfaction rates, and you don't have to go to sleep for it, and it takes just a few minutes at a surgery center. So operative release after 3 injections is a good idea. Steroids are not a great thing repetitively for any tendon because it can create degeneration of the tendon and things like that. So you probably don't want to continue to get injections.
So that's a conversation you need to have with your physician because you may need to go on to that next step. There's a number of questions about the carpal tunnel. Like you said, I do think so many people see this as an exercise physiologist. I watch people who hunch over and do all of this and they put all that pressure on their wrists. So I love the fact that you talked about that some of this comes from the nerve. This is where we could have that numbness in the fingers, that tingling. But is there other things that they should be looking at? Like how long does it take to recover from a carpal tunnel release? How quickly can they get back to things? And is there anything else that causes that tingling besides the carpal tunnel?
Right, great questions. So the carpal tunnel surgery itself, well, let's take a step back. What else could cause it? So if you had a herniated disc that was in the C5 or C6 kind of area, you may get tingling or numbness in that thumb and index finger. You could also have what's called cubital tunnel syndrome, where your ulnar nerve or your funny bone it gets pinched and it gets under pressure, and you actually feel numbness and tingliness in the small and the ring finger. So some people might think, well, God, that's carpal tunnel. Well, actually, that's called cubital tunnel. You could have a polyneuropathy. Maybe you have something going on, and a neurologist has to help you understand that. But as far as a surgeon is concerned, we look for things that we can release, whether it be at the neck level, which a spine surgeon would help you with, or at the wrist level or elbow level with, which I could help you with. Other things that can cause the nerve, it's kind of hard to say what else could cause that, but that's typically the high yield there for those particular diagnoses.
Something's ticking off the nerve. What if I sleep with my wrist bent? Can that lead to carpal tunnel? I know you were showing some pictures and someone asks, what happens if you do that?
Sure. So in the talk we were talking, and I probably went through it too fast. If your wrist is straight, studies have shown that if it's at about 2 degrees, maybe just a little bit back, okay, then the pressure in the carpal tunnel is at its lowest. Years ago, I think they actually did a study on medical students where we stuck needles in the carpal tunnel. It wasn't me personally, but and we measured the pressure. When your wrist is bent, the pressure is highest. When the wrist is back like this, it's higher, but when it's straight, it's at the lowest it can be. So if you've already got a high pressure in your carpal tunnel, and when you sleep at night like this, it's going to really raise it. You want to keep your wrist straight at night so that you don't have all of that extra pressure build up. So it is a good idea to sleep with it straight versus bent.
Excellent. Someone did ask about insurance, and I do think that it's a case-by-case basis. I would contact your insurance provider to see if why you're needing carpal tunnel is something that would be covered by insurance.
It is
Uh,
usually covered by insurance. I've never seen one that wasn't a problem, as long as we did all the conservative approaches first.
Excellent. And then someone asked about, and I am not going to pronounce it correctly, du Dupuytren, Dupuytr. Yeah.
Dupuytren's contracture, yes. And Dupuytren's contracture is a contracture of the palmar aponeurosis in the palm, and actually their hands can draw up. And it's actually related back to the Vikings, as we call it, from a European type descent. And we can see that contracture. And the test is if you can get your hand flat, if the bottom of my screen is flat, if your hand can lay flat on the table, that's pretty good. But if it starts to get like this, you're probably a little too far gone, and you may have to have a release of the contractures that are in your palm area. And it's typically the ring or the small finger that it occurs in.
I asked you too many questions and forgot to have you do this one. With a carpal tunnel release, how long is the post-op recovery for that? And is that seeing a physical therapist? What happens for that?
Sure. So yeah, I think I missed that one. So the procedure itself is relatively quick. After surgery, you're not in a splint, and I think a lot of surgeons are different. I don't use a splint. I just have a dressing on the hand for a couple of days. You're able to move the wrist and the hand right away. We usually restrict you from doing things that would protect the incision, which is about half an inch incision right here, and you protect that incision. You have 3 stitches. We take that out 6 days later, and then you're able to go back to work. But we don't want to get this infected, and we don't want you to put a lot of pressure on it. So if you remember in that picture, the carpal tunnel is like this, but with a ligament on top. We release that ligament, and then these bones can flex. And this is called a pillar, and this is a pillar. And patients can, when that flexes, they can get what's called pillar pain. And that's like putting your palm down. Not everybody gets it, but that can limit your return to work. But typically, if you're not a heavy laborer or something like that, you can be back to work in a week.
Excellent. Now, things happen. They're going to have to, sometimes accidents happen, but if you were to give people a tip or two as how to keep them from seeing you, what can we do to keep our hands healthy and have the best benefits to not have some of these issues?
Well, I compare a lot of what we do nowadays and how we can protect ourselves to airline pilots. They have a checklist. We've even in hospitals, they've gone so far as to pull these checklists into hospitals to be safe. during surgeries and things like that. And it's called Life Wings and things like that, programs and whatnot. And it's checklists that always keep you safe. And you just have to run the list sometimes. I always teach my kids and things like that. Whenever you've got a box knife in your hand or you got a knife or you're doing something, you want to look at where the knife will begin and where is it going to end. So what's my start point? Where's my destination? And you never want to have anything in between the start point and the destination. For example, I'm about to cut a box open, but my forearm is right there in the way of the origin, the destination, and beyond. Because if it slips, you're going to cut yourself. So you bring it up before, put it above the origin and bring down. So you can't hurt yourself with knife cuts and things like that. You have to think about that sometimes. You never want to be downstream from an instrument. You want to be upstream. As far as doing things, if you're out on a table saw or you're working, don't let things distract you. If you've got your buddies over and you want to show off how to cut a piece of wood, don't do it. Just do it in your routine, stick to your routine, be safe. You turn it on, you do it the same way every time to keep yourself safe. And that's a great recommendation for anything. Just like riding a motorcycle, I got to do this, I got to put my helmet on, I got to do that, and so forth. It's a checklist that keeps you safe, and anticipate the unexpected. Think it will happen, and then sometimes you can prevent it from happening.
That first slide definitely was an eye opener for me, with the picture going, got to make sure you stay safe, because it's so easy for something to bounce or to hit, like you said, or do something so quick you kind of get in the way. As an exercise physiologist, I always like to drill home. Think about, your checklist also is, if you're on the computer a lot, look about your positioning on the computer, because that can lead you to poor postures and put a lot of stress on your hands. Or if you play a specific sport or you're doing a lot of things, make sure you're looking at how your body is being held so that your poor hands and wrists are not taking the brunt of it. The rest of our body is supposed to help to carry some of that load. And sometimes we put a little undue force on them. And there's enough stuff that goes on in life. We want to make sure we're taking what we can, for our bodies. So again, always have to put
Absolutely.
my exercise physiology little plug in there.
Perfect.
Thank you so much. I think this was such an informative talk, because it showed the breadth of all the different things that happen. Again, to these little things that kind of carry around with us all day and are so important what we're doing, we need to make sure we're taking care of them. And if you do have an issue, make sure you're reaching out and having that conversation with your physician, because they're the ones who are going to be able to figure out exactly what's best for you. If you're not doing well with one treatment plan, there are other paths for you to do, but you have to have that conversation in order to be successful. So thank you all for being here. We will send a follow-up if you want to get a hold of Dr. Lewis. That contact information is on the screen right now with the website, or I will be putting it into the email. So thank you all for being here. We look forward to seeing you next month when we have Dr. Harris talking about how we can take care of our kids.
Thanks, Jean Marie.
Have a great day, everyone.
You too. Bye-bye.